I'd like to introduce our next speaker. Chris Hamerski is going to join us from here in the city. He has a dual appointment at UCSF at the San Francisco VA Hospital as an assistant professor. He is the director of luminal oncology, also the director of their International Interventional Endoscopy Fellowship Program at IES at CPMC. Chris, thanks so much for joining us.
Thank you very much. Okay, great. Excellent. All right, well, thank you for inviting me. It's an honor to be here. As Eric mentioned, I work at a group called Interventional Endoscopy Services with my partners Ken Binmoller and Andrew Nett and Rabindra Watson. We provide interventional endoscopy services as well as work part-time at the VA. So I was given the very challenging task of talking with you about the entire field of advanced endoscopy and also being the barrier between you and lunch. So I'm going to try to get through this in a kind of expedited manner. Hopefully have a little fun along the way. So we're going to talk about a number of different things, some of which kind of came about at this most recent DDW. We'll talk a little bit about prevention of post-ERCP pancreatitis. We'll talk about endoscopic sleeve gastroplasty as the 5-year data just came out at DDW. We'll talk about management of gastric outlet obstruction and how that's sort of evolving more recently. And also about how we manage acute cholecystitis, and that certainly is changing more recently. We'll kind of briefly touch on third space endoscopy, specifically GPOEM, and maybe briefly talk about altered anatomy ERCP. Unfortunately, there's a lot of topics that I'm not going to be able to talk about, which are very interesting and exciting at this time, like EUS-RFA of pancreatic neoplasms, endoscopic submucosal dissection, how we manage GERD endoscopically. We will talk a little bit about EUS-guided biliary access, but we'll not get to variceal ablations, gastrogastrostomy, and necrosectomy. So for anyone who does ERCP, we know that post-ERCP pancreatitis is one of the more dreaded complications that we face. We generally quote a number in an average patient of about 1 to 5% risk, but in those high-risk patients, certainly young females, suspected SOD, ampulectomies, that rate can be up to 25%, with a significant mortality rate of even 0.6%. So we all know about that New England Journal article that came out in 2012 that showed rectal indomethacin decreases the rate of pancreatitis in high-risk patients. We also know about pancreatic stents, that when we place those reduce the rates of pancreatitis. But unfortunately, we also know that when we try to place a PD stent, but we're unsuccessful, we've actually now increased our rates of pancreatitis. More recently, there's been studies on peri-procedural IV hydration, specifically lactated ringers. There's a number of different protocols out there, but one of the more common is using 3 cc's per kilogram per hour during the ERCP, followed by a 20 cc per kg bolus, and then additional IV fluid after that, typically for 6 to 8 hours. And this came about from a small pilot study by James Buxbaum in 2014, and they showed that the rates of pancreatitis were decreased from 17%, and they actually didn't see any in the intervention arm. And this was later confirmed by a large randomized trial. There have been a few studies that have suggested the benefits of sublingual nitrates, such as isosorbide dinitrate, glycerol trinitrate. And the idea here is that it's a smooth muscle relaxant and may relax the sphincter of Oddi, and as well as dilation of microvascular vessels and improve pancreatic blood flow. So this was an oral presentation at the most recent DDW, and then recently was published in Gastro from a group in Japan looking at a multi-center randomized trial of about 886 patients, and they randomized to getting Diclofenac PR, essentially like rectal indomethacin NSAID, alone versus getting the Diclofenac plus 5 milligrams of isosorbide dinitrate 5 minutes before the ERCP. And just getting to their results, they had, so in the combination group, they had 444 patients, where on the Diclofenac alone, 442 patients, so nice size. And what they found was that in the combination group that got the sublingual nitrates, their rate of pancreatitis was 5.6% compared to 9.5%, and that was statistically significant. If you break that down further into patients who had no risk factors for pancreatitis, obviously the rates are going to be low, and there was not a statistical difference between them, although it does seem like there may be a trend. And certainly in patients who do have a risk factor or more for pancreatitis, there was a decreased rate, although it didn't quite meet statistical significance. All right, so moving on to endoscopic sleeve gastroplasty. This has gotten a lot of press recently. As many of you know, it's an endoscopic alternative to sleeve gastrectomy, where the surgeons basically take out a part of the stomach and create essentially a tube through the stomach. It has very nice data in terms of weight loss. And we can now do this endoscopically, where there's a suturing device where you can essentially do the same thing from the inside. And the goal here is to reduce the volume of the stomach by about 70%. Its mechanism is, of course, by just creating a smaller gastric capacity, but in addition to that, also allows for slower transit through the stomach and probably induces hormonal changes as well that may be equally as important. And the 5-year data was just presented at DDW. So this is kind of a brief schematic of how this works, essentially a suturing device that goes down and sutures from the anterior wall greater curvature to the posterior wall, and basically just kind of sutures it down and creates a tube. I do have a video. This is courtesy of my partner, Ramindra Watson, who does this for our group. It's a little longer than I wanted to, so we'll probably fast forward here a little bit. But basically, the general idea is performing these APC markings to kind of serve as a marker of where the suturing is going to go. There's various different suture patterns that have been evaluated. It's kind of beyond the scope of this talk, but the general idea here is to basically bunch up the stomach to create this tube. So here's the suturing device you can see. Excuse me. There's a tissue retraction device, which is basically just like a corkscrew, which grabs the tissue, pulls it into the suturing device, and we can get full thickness suturing. And you just continue this along. So if you wouldn't mind fast forwarding to maybe about 3/4 of the way through, yeah, perfect right there. And we can kind of see a little bit more of what this starts to look like. So essentially just kind of pulling this together, making this tube, and then usually there's a second layer that's gone beyond this. And then you can see the suture being cinched down here. And the end result, again, is a narrow tube. You leave the antrum relatively intact. And this is just at the end here looking at how this looks. So in this study that was presented, this was 203 consecutive patients underwent ESG between August 2013 and 2018. And they included patients with a BMI greater than 30 who had failed non-invasive weight loss measures and were not considered surgical candidates or refused surgery. They excluded those with prior surgeries or bariatric procedures. Their primary outcome was percentage of total body weight loss. Most of these patients were female, 67%, with a mean BMI of 39, 29% of which had diabetes, and 54% had an elevated ALT. You can see here the distribution, mostly in that 30 to 40 range, but they certainly did have patients of 40 or above, and even a few above 50. And their data here basically is that within a year, they showed a weight loss of, total body weight loss of approximately 15%. You can see this was relatively durable. They did note that the maximum weight loss was achieved at about 24 months, and then there was a slight uptick afterwards. In general, the overall amount of kilogram weight loss was approximately 15 to 18. There was some weight loss, weight regain after this, usually an average of about 2 kilograms, but again, quite durable even at 5 years, which is impressive. And most impressive is that their adverse events are almost zero, less than 1%. They did have one patient with a perigastric inflammatory fluid collection that resolved with percutaneous drainage, one gastric perforation, although that was managed endoscopically. Now, certainly these patients do have minor side effects like post-procedural nausea and abdominal pain, but for the most part, those can be managed conservatively, don't require admission, and they can go home the same day. Now, you may say, well, how does this compare to sort of the gold standard of lap sleeve gastrectomy or even the gastric band? And this study was put out by the same group. and it was a retrospective study of 278 patients, and they looked at their 12-month total body weight loss, and for essentially the gold standard of lap sleeve was around 29%. For ESG is about 17%, and that's kind of in line with most of the studies. So certainly this is not going to be as robust as the laparoscopic sleeve, but in a patient who doesn't want to undergo a significant surgery, certainly less morbidity, this is a nice alternative. And again, we've sort of seen that anecdotally. We haven't published our data yet, but we're seeing a range somewhere in the 15 to 20% as well in terms of total body weight loss. So let's talk now about how we manage gastric outlet obstruction. So in the past, that certainly was with surgery, with a gastrojejunectomy, and then of course when enteral stents were introduced, that was kind of more the method of what we used. Looking back at a systematic review from 2007, we saw that stenting had shorter hospital stay, higher initial clinical success, and faster relief of symptoms, but that it certainly required more frequent interventions. In a randomized trial in 2009, the food intake improved more rapidly in the stent group, with long-term relief that was worse, however, in the stent group. And this is basically because of a higher complication rate. Essentially, there's tissue ingrowth into these stents, and if any of you have placed stents in these malignant gastric outlet obstruction, you know that it's only a matter of time before they reocclude. We know that about up to 40% of patients with these will require reintervention, and certainly if they live long enough, that number would essentially reach 100%. In patients who also have malignant biliary obstruction and require a biliary stent, that duodenal stent also increases our rates of biliary stent dysfunction, with a mean patency of only 64 days with a duodenal stent compared to 170 days without. So essentially, we know that enteral stenting is faster at relieving obstruction with shorter hospitalization, but has worse long-term outcomes. So in generally, what we've been taught is that when life expectancy is greater than 6 months, maybe even greater than a year, surgical GJ certainly is superior. It's going to give us longer, more durable response. But for less than 6 months, we should be doing enteral stents. However, I think there's room for improvement. So many of you have probably heard about this lumen-opposing stent. This is a biflange stent that can basically bring together two lumens. It was originally designed for pseudocysts, but we certainly now are expanding the use of this. This was actually developed at our center by Ken Binmoller. And it has an EUS-guided delivery system with an electrocautery-enhanced tip. And so we can now do gastrojejunectomies with this. The first animal study was published by Dr. Binmoller in 2012 with my former partner as well, Dr. Shaw. And this was just a feasibility study in 5 pigs, but showed that this was technically possible. This is a little schematic of how we do it. Essentially, we put a catheter into the jejunum, fill it with water, and then use our EUS scope and create that connection. I do have a video to show this. However, the data is, at this point, of course, limited to relatively small case series, which shows nice technical success as well as clinical success in the 90% range or higher. The adverse events in general are fairly rare, 10 to 15%, and most of these can be managed endoscopically. There was one patient that did require surgical revision. This study came out actually last DDW, and this kind of really has changed the paradigm of how we're looking at this, whether this was kind of the second line versus now really becoming the first line. It was a retrospective study looking at EUS-GJ versus enteral stenting. They had 100% technical success in both arms with similar hospital stays, but they found higher stent failure requiring reintervention in the endoscopic stenting group, as well as higher adverse events. And so really now, this is the paradigm is kind of shift for these malignant gastric outlet obstructions. We're not really doing many enteral stents anymore. Almost all of these are getting EUS-GJs. So we'll also talk a little bit about the instance of when we have malignant biliary obstruction plus malignant enteral obstruction. This is what often happens when these patients, when these tumors in the head or the incident obstruct and we no longer have access to the antrum, so we can't perform traditional ERCP. So our options for this, we could do a surgical double bypass, which is a hepatocojejunectomy and gastrojejunectomy. This is obviously quite invasive. We could put in a percutaneous drain plus an enteral stent. We could do so-called EAC or EUS-guided enterograde cholangiography, essentially putting our EUS scope in the stomach, puncturing across the wall of the stomach into the left intrahepatic duct, getting a wire down, and then anterograde, placing a stent into the jejunum. We don't ever have to reach the ampulla, and then placing an enteral stent after that. We could do EUS-guided choledochoduodenostomy, so we basically place that same lumen-opposing stent from the duodenal bulb into the bile duct. So again, we don't have to reach the ampulla and then also place an enteral stent. This is what that might look like. You can see the lumen-opposing stent right here going into the bile duct, and then this is the enteral stent. However, we've seen anecdotally by doing this, what happens is you get stasis of food right here, and then you can obstruct your lumen-opposing stent right here, and you have more episodes of cholangitis. Or what we're doing now is basically EUS-guided choledochoduodenostomy plus EUS-GJ. I do have a little video here. There's a 65-year-old woman with metastatic colon cancer. She presented with abdominal pain, nausea, and vomiting. You can see a massively dilated stomach right here. And there's going to be a tumor here causing obstruction of the stomach and the bile duct. On EUS, we saw large lymph nodes, dilated PD, and a massively dilated common bile duct, which you can see here. As we follow the bile duct down, we can see it's obstructed distally. And again, in this case, we can't reach the ampulla, so we go ahead and puncture into the bile duct using that electrocautery enhanced tip. A wire is placed, although that's not necessarily needed. Or in this case, we're using a 10 millimeter lumen-opposing stent. The distal flange is deployed, tugged up against the wall of the bile duct, and then the proximal flange is deployed. We've now created a connection between the bile duct and the duodenal bulb. The stent can be dilated up to 10 millimeters, and then for technical reasons, we oftentimes put a double pigtail stent across that just to ensure patency. So now we turn our attention to the duodenal obstruction. Scope cannot pass, so we'll go ahead and pass a ERCP catheter. Here I am advancing the wire, trying to snake this by the obstruction. At this point now I'm injecting contrast, and you can see the normal jejunum downstream of the obstruction. Now we're going to be advancing a nasobiliary catheter, which essentially will allow us to instill fluid and contrast into that jejunum so that we can see it from the stomach. I'm removing the gastroscope, leaving that nasobiliary tube in place. So now the patient will have a nasobiliary tube sticking out their mouth. Now in EUS, you can nicely see that dilated jejunum that we can instill with water, and we're puncturing in with the lumen-opposing stent. A wire can be placed if necessary, although technically we usually don't do that anymore. Deploy the distal flange of the 15 millimeter lumen-opposing stent, hug that up against the wall, and then go ahead and deploy the proximal flange. And the gastrogastrostomy has been created. We can dilate that stent up immediately to 15 millimeters, exchange for a gastroscope, and now we can see our gastrogastrostomy is patent. This was a case I did, I think, approximately 2 years ago or so. And so for this case, I did admit the patient and watched overnight and got an upper GI series. I don't do this anymore, but it's nice in that it shows us how patent this is. So this is the upper GI series. You can see the contrast coming down and pretty rapidly filling through the gastrogastrostomy. So now let's move on to how we manage acute cholecystitis, as this is probably going to be changing. Typically, this, of course, is managed surgically, but in patients who are high risk, who either have significant sepsis or maybe have significant comorbidities, these are often managed with percutaneous cholecystostomy tubes. However, there have been some retrospective studies that EUS-guided gallbladder drainage may be superior to percutaneous drainage. So we, of course, can do the same procedure that I showed you with the bile duct. We can also do that into the gallbladder, either across the duodenum or across the stomach. So this was presented at the last EDW by Anthony Tiao, and he did a prospective multi-center randomized trial of 5 high-volume centers in Asia. They included patients with acute cholecystitis who were deemed high risk for cholecystectomy or refused surgery. Their EUS gallbladder drainage was kind of, as I discussed, basically going either across the wall of the stomach or the duodenum. In our practice, duodenum is preferred. And they can use either a 10 millimeter stent or a 15 millimeter stent. And then that allows you to actually even go across it in the same session and potentially even remove stones in that session. Percutaneous drainage was just standard technique. They did do 1 month follow-up with cholecystoscopy, so meaning putting a scope out across that lumen-opposing stent into the gallbladder, and they could clear any stones if they saw them. If they were able to do that, they removed the lumen-opposing stent and placed a 7 French double pigtail stent across that anastomosis. They also did a 1 month follow-up in the percutaneous group as well. But if there was still an obstructed cystic duct, then they left that percutaneous drain in long term. This is a very busy slide, but basically, if you pay attention to here where the p-values are significant, their biggest finding here was the rates of adverse event. So at 1 year, we see adverse events in the percutaneous group of 77% compared to only 25% in the EUS-guided group. Likewise, there was less interventions at 30 days in the EUS group, less unplanned admissions, and less 30-day adverse events. Technical success, clinical success, all equivalent between the groups. Procedure time, hospital stay, also equivalent. Not surprisingly, these patients who underwent the EUS gallbladder drainage had less pain. They didn't have a drain sticking out of them, so that makes sense. And so they concluded that the gallbladder drainage by EUS reduced 30-day and 1-year adverse events, post-procedural pain, recurrent acute cholecystitis, reinterventions, and unplanned admissions, and that this should be the procedure of choice in high-risk surgical patients, provided expertise is available. So this is really changing the paradigm of how we manage these. In speaking with Dr. Tiao, I think this is going to be submitted to the New England Journal, so watch for that. So we'll touch a little bit on third space endoscopy. So all of you are very familiar with what we call the first space, the GI lumen. Hopefully we spend most of our time there. But we also have the second space, which is beyond that into the peritoneal cavity. So this would be like notes, natural orifice, transluminal endoscopic surgery, intentionally creating a perforation to go out of the stomach and do interventions. But more recently, we have the third space, which is basically the submucosal space. We know that this basically allows us to tunnel through the submucosa and perform all kinds of interventions. So like for achalasia, I think it's pretty well established at this point that POEM, or per-oral endoscopic myotomy, is the standard now over surgical myotomy. For subepithelial tumors, we can do STIR, or submucosal tunneling, with endoscopic resection of these subepithelial tumors, and then go ahead and close up our tract. For mucosal-based tumors, we have ESD, or endoscopic submucosal dissection. For Zenker's diverticulums, we have Z-POEM. And for gastroparesis, we have G-POEM. We know that gastroparesis is very difficult to treat. In a large randomized trial in 2015, we saw that only 28% of clinical success at 48 weeks with standard treatment. So this led to the introduction of G-POEM, which is a minimally invasive endoscopic treatment for refractory gastroparesis, which was first introduced in 2013. The basic idea here is that we go ahead and do a submucosal tunnel, inject into the submucosal space just like you would for a standard injection-assisted EMR, and basically dive into that tunnel all the way to the pylorus. We can see the pylorus here, and you can do a myotomy. I do have a video here. This is full disclosure. This is not my video, but this was a nice video here. And so basically, inject into the submucosal space and then use needle knife. There's a number of different needle knives that we can use to make an incision here, and then work our way into that submucosal space. This is very familiar to anyone who does ESD. This look here. And so basically we would perform a tunnel through the submucosal space, kind of painstakingly cutting each of these individual fibers, identifying blood vessels, coagulating blood vessels, and making our way through the tunnel. If you wouldn't mind advancing the video maybe to about halfway through. Can you advance the video? Just in the interest of time. Yeah, perfect, to about right there. And then you can see here the myotomy is being performed. And then after the myotomy is performed, you can back the scope out basically and close up your mucosal defect. So this was presented at the most recent DDW. It was an international prospective trial of 6 centers from November 2015 to May 2019. Inclusion criteria were gastroparesis, which were refractory to standard medical therapy, and they excluded prior gastric surgery. They defined clinical success as a decrease in the gastroparesis cardinal symptom index score, which included symptoms such as postprandial fullness, early satiety, nausea, vomiting, and bloating. And they also looked at quality of life as well as gastric emptying studies. With kind of the standard etiology of patients of etiologies, diabetes, post-surgical, idiopathic. A number of these patients had already received interventions prior to this, Botox, transpyloric stenting, et cetera. And they found relatively nice clinical success after GPOM with rates around 59%, and this was relatively durable even up to 12 months. Likewise, symptoms of bloating, fullness, nausea, and vomiting also decreased after GPOM. There was a number of quality of life factors that were positively influenced, such as physical functioning, energy fatigue, social functioning, and even pain. And also even looking at the gastric emptying studies, they found that the rates of 4-hour retention were decreased from 41% pre the GPOM to 25% after GPOM. The rates of adverse events were relatively infrequent, about 7.5%. Most of these were mild and easily treated. There's also another study looking at GPOM versus the gastric electrical stimulator. And the bottom line here is that the GPOM was superior to the gastric electrical stimulator. So they concluded that GPOM has potential to become a frontline therapy for refractory gastroparesis, but research is needed to identify candidates likely to respond to GPOM. And this is something that our group is currently looking into right now. So we'll talk briefly about altered anatomy ERCP. For any of you who do ERCP, you know that this is one of the banes of our existence in these patients who have Roux-en-Y. We have a number of ways of trying to gain access, one of which is laparoscopic-assisted, where the surgeon puts in a port and we can put our scope in through that. But there's multiple issues with it, including timing, sterility, trying to just get yourself to the OR. There's a number of surgical complications with this, with adhesion. Sometimes it can take a while just even getting that port in place. It requires a very large trocar to be able to put our scope down. And there's not insignificant adverse events with this lap-assisted technique. One of the things as well is that the angle of our scope is very different than what we're all used to, kind of coming down from the esophagus. And so it comes basically from the side here, and it has to make a very sharp angle. And so you have to be very careful not putting too much pressure out here. And I've heard anecdotally of perforations out here. We can go ahead and do deep enteroscopy. This is certainly a very challenging procedure, trying to get either a colonoscope or a single balloon or a double balloon enteroscope. And I'm sure we've all seen or heard of this where we have our scope on fluoro like this and we think we're almost there. We're not even halfway there yet. We're already an hour into the procedure. We know that access rates, even once we get there, are not particularly high, with cannulation rates of about 68 to 95%. People have also looked into doing PEG tubes into the excluded stomach and then upsizing this. I won't touch too much on this. But like a lot of things, the EUS has helped us out a lot in this. We oftentimes use EUS-guided anterograde cholangiography or EUS-guided ERCP. Essentially, the idea is we're using EUS to visualize the left intrahepatic ducts, take a needle, inject that into the left intrahepatic duct, get a cholangiogram, advance the wire down, and now just like IR, we can do a lot of our interventions anterograde. So dilate that tract, we can do balloon sphincteroplasty, anterograde stone extraction, just push the stone down. We can even, in malignant obstruction, place anterograde metal stents as well. And also it has the added benefit, and if we can't successfully perform an intervention, anterograde, we can potentially even just put a wire down, advance that far into the jejunum, and then now if we need to go long limb enteroscopy, at least we have that wire, at least we have our access there. But we know that this is fraught with significant adverse events. It's a very technically difficult procedure and really should be in expert hands only. So this has led to a more recent procedure called the EUS-directed transgastric ERCP, so-called EDGE procedure. The basic idea here is we're going to put our EUS scope into that gastric pouch, see the excluded stomach, and fill it up with water in contrast. And then we can go ahead and place a lumen-opposing stent across that and make a gastrogastric fistula. Now we can go through that stent and perform ERCP just like we normally would in normal anatomy. And then so you can either do the ERCP immediately, or if you want to be more safe and have the luxury of time, let that tract mature, go through that stent, and then perform ERCP. This is a brief video demonstrating this. We can see a stone on MRCP. So in this, we're using FNA needle to puncture into that excluded stomach, filling it up with water and, if needed, contrast. And then go ahead and doing our lumen-opposing metal stent placement, puncturing into that excluded stomach. Deploying 20 millimeter lambs, we want to use a wider diameter so that we can get our ERCP scope through that. The proximal flange is deployed, as we've seen in prior videos. And then now you have that conduit, you can remove your stent, put down your standard duodenoscope, go through the lumen-opposing stent. So first we dilate up to 20 millimeters. Again, there is the issue of whether or not we do this immediately versus wait. If you have the luxury of time, certainly it is safer to wait, allow this tract to mature. But if there is urgent cholangitis or urgent need, you can do it in a single session. And then ERCP is just performed as you guys are all familiar with. So there's a number of studies comparing these. I've highlighted just a few, looking at laparoscopic-assisted versus enteroscopy. And the bottom line here is that lap-assisted has higher success rates, certainly, but also has higher adverse events. The complication rates in the lap-assisted group was about 18%, so not insignificant. If we look at EDGE now compared to lap-assisted ERCP for Roux-en-Y, we see that the technical success for both is quite high, approaching 100%, and adverse events were no different between the two, but with less procedure time and less length of stay for the EDGE procedure. Now, if we compare EDGE versus enteroscopy ERCP, certainly as expected, EDGE is going to have much higher ERCP success, essentially 100%, versus enteroscopy, which is only about 60%. Procedure time is certainly less, possibly even half as long, with less adverse events. And interestingly, we do not see a weight change. It's obviously one of the concerns is now that we're creating a gastrogastric fistula, the patient's going to regain weight, but luckily we haven't seen that. We can get that back out. And then if there is a persistent fistula, which usually there actually isn't, usually it just closes up on its own, but if need be, we can suture that back down. This is a very busy slide. I'm certainly not going to go through all of this, but just to kind of highlight what our own practice is previously we were, our first line was anterograde EUS, using EUS to try to do all of our intervention. Anterograde followed by rendezvous if needed. But now we are moving more to an EDGE predominant procedure. And so that is really changing the paradigm of how we're managing these and making post-Roux-en-Y patients not such a headache. All right, that's it. Any questions?